Good morning, everybody, and welcome to day 2 of the Technical Framework for Trusted Exchange track, part of ONC's 2020 Tech Forum. Whether you joined us yesterday or are participating here for the first time today, we've got a great lineup of speakers for you. Really excited for all of the good content we have to share today. Before I kick things off, I really just wanted to take a moment to thank all of our panelists and all of the moderators today, as well as everybody in the audience for taking the time out of their hectic schedules to attend this Tech Forum. We really do appreciate your support and ongoing efforts to improve our healthcare system and delivery of care for patients everywhere. Yesterday, as part of this track, we had 2 excellent panels really looking at a lot of interesting aspects of health information exchange, including some of the innovative services that HIEs are providing today, and some of the privacy and security challenges that we have to manage as we push this healthcare system to a more interoperable state. Today, we're going to start off with a panel discussion about the challenges and opportunities associated with data integration and use. As you are all aware, I'm sure, one of the largest impediments to achieving the vision of a learning health system is the quality of the data that's being collected and exchanged electronically. And so each of the speakers that we have for you this morning have had to address and navigate these different challenges related to things like disparate implementations of standards and some other data quality issues. So if you go to the next slide, I will quickly introduce our speakers and then turn things over to Marty. So our 3 speakers this morning, we have Martin Lupinetti, who is President and CEO of HealthShare Exchange, which is an HIE in Pennsylvania. We've got Dr. George Hripczak, who's chair of the Department of Biomedical Informatics at Columbia University, among other titles, and one of the leaders of the Observational Health Data Sciences and Informatics program, also called Odyssey program. And finally, we've got Mitra Roca, who is a senior medical informatician at the Office of Translational Science at the Center for Drug Evaluation and Research at the FDA. So without further ado, I will turn things over to Marty to get us started.
So thank you, Alex. Thank you, ONC, for inviting me here today. Can you all hear me okay?
Yes.
Okay. All right. So HealthShare Exchange, as Alex spoke about, is really a organization, a grassroots organization that really got built by the health plans and health systems that are part of the greater Philadelphia region. And it really was a community-driven effort, right, that really got this started. And you know, you probably have heard this saying, but, you know, data sharing goes at the speed of trust. And I think that's absolutely the case with this community and the way HealthShare got its start. It's something that I've been extremely passionate about and really part of from the very beginning, right? I kind of helped craft the original business plan and brought the stakeholder community together, although a credit to this community and the folks out there, the healthcare stakeholders, the plans, the providers, the health systems for really trying to make care better and support better transitions of care and really make the patient experience better. And that was really how HealthShare got created. Next slide, Jennifer. So this kind of speaks to our beginning with the patient really being the center of our decision-making, the center of how we evolved various services and use cases and so forth. And we started in 2012. We were a nonprofit HIE. So I like to say that we're neutral. We're sort of Switzerland in between all these different stakeholders and all these different members and different types of organizations that really spread or across the entire continuum of care. It's a very diverse and broad membership that's really recognizing that there's value in getting near real-time data and being able to share that and use that in a variety of ways to influence and improve care for the patient. We think we're unique in the way that we've got now 10 health plans that are part of us. And they're not just contributing financially, but they are contributing data. They are an active user of our services. And they really were the catalyst and saw the bigger picture of sharing this information and allowing this information to flow and be brokered really could provide a better experience, less costs, more effective, better care. So they were really part of this. And you see the high trust certification symbol there in the lower right. That's really something that we take a lot of care and attention to. We've had to really raise the bar for level of security to really maintain that trust and ensure that that trust is always there in the way we're handling the data, who gets to see the data, how is the data shared, and with whom. So we really take careful attention to our security program and privacy around the HIE. Next slide, please. This slide kind of speaks to our volume. So Alex said we're in the Philadelphia market. That is absolutely true. That's kind of our core area and where we started. But this has expanded. I like to call us more of a mega regional HIE, and it kind of expands well beyond the Philadelphia and community around Philadelphia, but now it's into South Jersey, it's into Central Jersey, it's up into Northeast Pennsylvania and Central Pennsylvania. So we've continued to grow this. We've got about 62 hospitals now that are contributing data on a near real-time basis. I mentioned the 10 health plans, but you can see over 12 million individual patients we have collected data on. That's growing and getting better every single day as we're adding more to it. We've got about 83,000 providers there. Some are part of the health systems and came along with them joining Health Share Exchange. Some are just independent specialty practices, city clinics, ACOs, long-term care, post-acute care, and on and on. You can see that we've got 400 plus entities that are connected and part of a single data sharing agreement that really has held up and has stood up with both plans, providers, and all those other kinds of entities I just described. That was a big step to kind of create the scale that we're at today. The other last point I'll make on this slide is we have a service, an encounter notification service that, again, is pretty much real time. We offer it in a variety of ways, but based on a patient getting admitted, discharged, or transferred, we have that information and we're able to share it through a subscription model. So about 6.5 million patients every single day are being tracked across this mega region using that service. Next slide. So, part of this with understanding, how to take in data, use the data for pop health and so forth, I needed to at least spend a minute or two on our pandemic response. It's been quite a transition to what we were doing back in January and early February to kind of what then transpired and that we've all experienced. This is part of some views of reports and information that really the region, the city of Philadelphia, Public Health Authority, and the state were really lacking. They didn't have a clear, quick way to get to detailed demographics or information on COVID patients, their age, their ethnicity, and so forth. And we had it. So that was one of the steps we took, is really with the Health and Human Service federal waiver for data sharing, we embarked on getting more information shared with our public health authorities, both city and state, but also our regional stakeholders. They were really not able to see a complete picture of what was happening happening to their peers, their counterparts. And in some cases in the city, less than a couple blocks away, and we had that information. So we started to produce a daily report. We also came up with smart alerts, a way to really trap on the COVID ICD-10 code and the various codes that I know we sort of transitioned to as the World Health Organization kind of landed on certain codes and so forth. We were providing kind of this smart alert that anytime a patient were diagnosed or lab test positive with one of those codes, we were then alerting their primary care physician so they could take more action, more proactive action. Since then, we've continued to explore other ways to offer value. A lot of learnings came out of this around gaps in the data quality, adding additional data senders, right? We had a lot of post-acute, but not all. And we know post-acute was where a lot of COVID patients were, and a lot of concern there, and how to track that and understand that better. We had some of that visibility, so we're in the process right now of really coming up with our own action plan for how to approach a wave 2 if that were to hit this region. We also saw field hospitals and field lab testing facilities where there was really no clear data sharing going on. Some of it was done manually by paper and so forth, or fax. So we believe there's a significant utility for Health Share Exchange or an HIE to really play a critical role there. And what we're doing more recently is supporting contact tracing with the city of Philadelphia. We're offering our data and really our master patient index, our index of patients, almost as a white pages for the contact tracers here in the city to look up contact information, phone, address, so they can reach out to folks in a more quick, efficient way. And we have a lot of detailed, accurate contact information on patients. So that a little word on the pandemic response and just how it really forced our whole business to pivot. So next slide. One thing I wanted to quickly share, and this is something that I think has a lot to do with data sharing and how we view it and how we believe we can enable many different ways to support the needs of our providers, of our plans, and also of the patient, and allowing them access to their information. So one of the things we came up with a couple years ago is a marketplace. We call it Market Street, HSX Market Street, given we were founded on Market Street here in Philadelphia. But it's really a curated platform that has FHIR-based APIs, custom-based APIs, standard-based APIs for really accessing very precise information and leveraging all of the HIE capability that we built over the last several years. So if you think about, we have a whole ecosystem that we've built. We have connectivity in and out of EMRs. We've connected probably and deep integration into 35 plus EMRs, Epic, Cerner being the two most prominent in this region, but there's a variety of others. So we're able to go in and out of workflow in a provider and add information or take information out. And we have the data use agreements, right? And the HIPAA compliant way of data sharing already negotiated, already in place. So it really adds a quick way for our community to get access through this API platform. So it's something we launched in March of 2019, and you can see all the different ways that data and applications could come at this platform for remote monitoring, telehealth, predictive analytics, for care coordination, and a variety of other chronic disease management type applications and products. So we are in the process of onboarding about 6 different products right now that our members have raised their hand and said, this is something we believe we need and would be value to quickly gain access to this ecosystem. It's almost like a connect once to many sort of curated marketplace. So we hold a lot of potential and promise in this new way of sharing data and allowing our providers to get additional value, our payers to get additional value for their members, and then for the patient to consent and authenticate and gain access to their own data. Next slide. So I'll conclude with just a few use cases that I think kind of are very relevant and more recent that have come up that we are now part of and implementing and really in support of. So one of the things that just last month, actually, we signed with the American Diabetes Association to be their partner in chronic disease management and population health initiatives for this region. So it was a very a big deal for HSX to be to have this strategic partner, and we're really being pulled into all their initiatives and new initiatives that come online to really help enable baselining of chronic diabetes in this region, what care protocols are in place that maybe could be further implemented to improve and manage that chronic disease. So we're very happy with that strategic partnership, and it's something that we think has a lot of additional capability. So we're just in the throes of that, but very excited about that. In addition, we've been in a variety of grant program discussions with Robert Wood Johnson Foundation, and given the pandemic, they pivoted some of those grants and focused on creating a national health registry for COVID-19 patients, something that our members, in particular Jefferson School of Population Health, among other national health systems, find very interesting. So they've kind of put us in the middle of that conversation to really create this national registry, to do a variety of analytics and research and learnings from that national registry. So again, that's something we're in the early stages, but I wanted to share with you all that that's something that I guess if there's a bit of a silver lining around the pandemic, this was one thing that's come out of that really gained some momentum there. One of our non-traditional healthcare stakeholders, MANA, they're located here in Philadelphia. They deliver food to chronically ill patients. They do this across the state of Pennsylvania and beyond, but they're primarily focused here in the greater Philadelphia region. We started to engage them with data that could better target their efforts and know what's happening with their patients that they are delivering food to, and when to maybe shift or adjust the food delivery or the diet and the restrictions that may be related to their illness. So our near real-time data is very valuable for them. They're able to get a very clear view of the patient up to the day, up to the hour of what's going on. And now we're talking to MANA about their dietitians actually contributing data back to HealthShare on some of the diet restrictions or changes in diet or things they've noticed with the patient based on the food delivery that really could influence their care. So that's something that we see, again, a lot of promise and additional potential. And probably the most recent use case or example of some data sharing that I wanted to bring to you all is with the state and Department of Aging for Pennsylvania. The Commonwealth of Pennsylvania sees the HIO community as really critical to how they care for seniors and Medicare patients across the state. And one area is the Prescription Assistance Program, the PACE program, that we've engaged to really help identify seniors that could be eligible for Medicaid assistance and funding of their medications, a program many seniors didn't even know they either existed or qualified for. We're able to get to the qualification list quicker for those patients, and then PACE can follow up with them very quickly for the application process and turning on this program so they adhere more closely to their medications. Again, less emergency room events and less cost and so forth. So we think that's going to be an extremely valuable partnership for this region and for the state. So again, I want to thank you all for this time, and I'll turn it back to Alex.
Thanks, Marty. So let's move on, and please feel free to drop any questions you have in the Q&A box, and we will try to get to those at the end. So let me turn things over now to Dr. Hripczak.
Thank you very much. And thank you for the invitation this morning. So I'm going to be giving an example of health data integration and go over some of the data-related challenges and how we've then put that into practice. Jennifer, can I have the next slide, please? So the Observational Health Data Sciences and Informatics, or ODYSSEY initiative, is a multi-stakeholder, interdisciplinary, and international collaboration coordinating centers at Columbia University, and I'm the director of that. We have about 300 researchers from 30 different countries. Shown on the map are collaborators. It's mostly, or about half the US and half outside the US. That underestimates the number of collaborators because about 3,000 people participate on our research forums on the internet. We have informaticians, people in statistics, epidemiology, clinical sciences, software engineers, et cetera, from academia, government, and industry. Our mission is to improve health by empowering the community to collaboratively generate evidence that promotes better healthcare. And that's one of the main points of what I'm saying today, is that as you try to bring data together and you build and you create standards to accomplish that, it needs to be driven by the science. So there has to be a goal in mind. There's many decisions that get made anytime you're designing a standard or assembling a database, and those decisions should be driven by the goal that you're trying to accomplish. We've amassed in our federated database, so we have data integration, but we're not physically putting the data in one database. We have a federated database of about 600 million unique patients, so about double the US population. Almost 10% of the world's population is in our federated database. Now we have about 2 billion patient records, but that includes the redundancy. For example, someone might be in a claims database and also an electronic health record and so on. So our estimate is about 600 million total unique patients around the world, split among 100 sites, more or less. So now on the next slides, I'm going to go into a little bit more technical detail. Here's how ODYSSEY works. On your side of the firewall, you have source data. That could be a hospital, a university. It could be a data aggregator. It could be even a government. So you have your source data stored in your own warehouse with your own source codes, and we ask you to convert to our common data model. We call it the OMOP Common Data Model. OMOP stands for Observation Medical Outcomes Partnership. OMOP is the previous name of ODYSSEY. When ODYSSEY split off and became an independent entity, it renamed itself that, but we didn't rename the data model because we don't want people to get confused and think that it was a new data model, but we maintain the OMOP data model. It takes some time to convert your data to the OMOP data model. Usually an analyst might take 2 months working on this, and then it's a year or years-long process to continually improve that conversion. Now, I'm going to say this again later on, but no source data or no information is lost because we always preserve the source code. So we have the source codes plus some map codes that I'll cover next. Not yet, though. And then we put your data into this new format. And then ODYSSEY is an open science format. Everything is public. So we created, when we run a study that's published on the internet, everyone can read it. When we create a study, we put the source code on GitHub. So if a participant, if a data source wants to participate in a study, they simply download the source code from GitHub, run it on their database, review the results, and decide to send it centrally, where we then collaboratively generate the report, usually a paper submitted to a journal with many, many authors, just like the physics community has CERN, where there's many authors, so ODYSSEY does the same. Let's see, next slide, please. So here's how we, here's that common content. As I said, it takes a lot of effort to put the data in this. Well, it's not 1 FTE for 2 months is not a huge amount. But what we're finding is sites are thanking us because when they convert this data model, they actually find errors in their original coding through our data quality checks that lead them to go back and improve their source database, never mind their participation in Odyssey. So we found that it's cost beneficial just from the point of view of improving your own database. Shown here, this slide, for those who are technical, is a data schema. It's a deep information model. This is version 6 shown here. There are many ways to do a data model like this. The important thing about Odyssey, now this model has been 10 years in the making, and it's been continually improved through tight coupling with the research that occurs. So as I said earlier, there's many decisions that you make in the course of defining a data model. How do you make those decisions? Well, it's driven by the research you're trying to do. One way to do this is just to have one table. It's called an entity attribute value table, an EAV table. It's very flexible. You store everything, but we found that researchers get confused by that. So we split our table into rational types. The rectangles shown here are separate tables. So the condition table contains the diagnoses. You see visit, drug, procedure, device. Measurement includes labs and visits, narrative notes. And you see the word observation on the lower left. That table is actually an EAV table where you can store anything that doesn't fit in our current data model. In the center, you see derived elements. That's where, for example, we infer from the fact that a drug prescription was fulfilled or that a drug prescription was written over a period of time, say every month or every 3 months or whatever, or every 90 days, that the patient's been on a drug continually, and store that in the table. And on the right are the tables that that define our vocabulary. If you could go to the next slide. So the Odyssey vocabulary is built based largely on work of the US NIH National Library of Medicine's Unified Medical Language System, or UMLS. We use their mappings and we supply feedback to them and supply them mappings. The way Odyssey works is it picks several standard vocabularies following the US ONC standards, like LOINC for laboratory tests, ARCS-norm for medications, and we use SNOMED as our main diagnosis vocabulary, converting from things like ICD-9-CM, ICD-10-CM, read codes in England, ICD-10 non-CM, say for other European countries. Our vocabulary has 7 million terms, and each of those terms is mapped to the standard that we use, so that whether you're in any country in the world or any institution in the US, your data are in the exact same, so that when we do a study, we're using the same exact database. So we can, from one site, distribute, send a query to send a study design to GitHub. Everyone can download it, execute the study, and have a rational result. As I mentioned earlier, we don't lose any source information. The source codes that it came from, say it's old US data, so it's ICD-9-CM. That is stored in the diagnosis table along with the mapped result, which is the SNOMED code. Let's go to the next slide. Those of you who are perhaps more technical and have been in this for years know that when you have a standard and the same data, if you give it to 2 different people, they'll end up with a completely different implementation. That is, I remember 30 years ago with HL7 version 2, you had 2 institutions coding the same thing, both using HL7 version 2, yet the 2 versions were were completely different from each other. So what Odyssey does is it uses standardized conventions for representing information. So a lot of our work through what's called the Themis group, the Themis work group, work on if you have data of a certain type, here's how you encode it in that standard. So if you have ICD-9 coming in like this, here's the table it goes in, here's how it gets converted, say, to the SNOMED codes. Or if you have racial information, ethnicity information, here's how it should get coded. If you have multiple assertions about the gender, here's how those multiple assertions get coded in our tables, and so on, or multiple races. So the theme group, each new implementer learns from previous experience. And again, it's that tight coupling where people are actually converting their data or actually doing the research, feedback the problems that they encounter and feed them back to these groups that then basically create user manuals of how to convert your data to a common data model. Not shown in the slides, but I'll just say a critical part of Odyssey and a large amount of time for the conversion is data quality. So our data quality dashboard has a large knowledge base of consistency checks and visualizations so that once you convert your data, you look at it and see what went wrong. So for example, in our database, if asthma was missing in 2005, that's odd. We know that we were still treating asthma in 2005. Well, it turns out the clinics changed, the codes got messed up, and we had to fix that in our source table because we know we had asthma in 2005, not just in the Odyssey database. Next slide, please. So the end result is that we use these data to carry out real research. Shown there is the Lancet article on hypertension meds, our study of all the classes for treating hypertension, including diuretics, seeming to be more effective than ACE inhibitors, was published in a top journal. Not shown here, my paper in JAMA Internal Medicine on diuretics, chlorthalidone versus hydrochlorothiazide, showing the safety risk of the first one, is not only published in JAMA Internal Medicine, but is already incorporated into the medical letter recommendations for how people should treat hypertension. The PNAS, Proceedings of the National Academy of Medicine, National Academies of Science, paper on treatment pathways looked at diabetes, hypertension, and depression. The FDA posted a question about levetiracetam and angioedema. Odyssey took it on and published it in Epilepsia. The last one shown on the upper right shows the reliability or lack of reliability of observational evidence and how Odyssey aims to address it using these data. Finally, and actually just yesterday, we heard of a paper on clotting published that will be coming out in JAMA from Odyssey. For COVID research, we had to spring into action. Now, this was a new thing. Odyssey is used to working slowly moving your data to a format so that we can do combined research and so that we can make sure we do all the data quality checks. COVID comes along and then suddenly it's an emergency. The big challenge there was at the very beginning, there were no source codes, and I commend the standards organizations for very quickly coming up with the codes. Unfortunately, organizations had already picked their own separate ways of coding it, so they incorporated the new codes but did it differently. So that was a big iterative loop to get organizations to change the way they're coding it, to use the new codes correctly, and transform it to a common Odyssey database. At this point, we have over 1 million COVID positive patients of about 5 million patients tested, about 250,000 who have been hospitalized. Our study of hydroxychloroquine and azithromycin was used by the European version of the FDA, the EMA, for its decisions and was shared with the FDA. We also have effectiveness studies. We've been looking at characterizing disease, who gets it, who's at greatest risk, susceptibility, showing that in fact you're not at greater risk if you take certain drugs like ACE inhibitors and ARBs, and prediction models of when is it safe when someone comes in with symptoms to go home versus will they decompensate and need to be intubated. So we've been working actively in the COVID-19 research. It was probably the most challenging data harmonization problems we've addressed because of the importance and the speed with which we had to do it. But we amassed a large database, and I think we're producing good evidence. But my main point of this slide is that you need to be producing evidence and feed that back to your data harmonization effort so that the decisions you make support the use case that's most important. And I will stop there. Thank you.
Great, thank you, Dr. Hripczak. We will now turn things over to Mitra.
Yes, thank you for inviting me. Next slide, please. So I'm going to provide an overview of a project that I lead. It's called Common Data Model Harmonization and our accomplishment of phase 1, and we are in phase 2, and then how we are leveraging the infrastructure stood up for this project in COVID-19 activities. Next slide, please. So the goal of this project, which is actually the vision of our former commissioner, Dr. Califf, is to build a data infrastructure for conducting research using real-world data. Real-world data is data from electronic health record, administrative claims, registries, and mobile health devices. And the objective of this project is to harmonize several common data models from different networks, one of them Odyssey, as George mentioned. And the goal is to be able to provide researchers from NIH, FDA, or academia with a larger pool of data to be able to ask their questions. And then the second objective is to be able to leverage open standards and control terminologies in this project. Next slide, please. So this is the 4 common data model we selected for this project: Sentinel, ITB2ACT, PICORNet, and OMOP. And this is similar to the different outlets. And then the white adapter is what we built to be able to harmonize these 4 common data model with a Uber model or intermediary model. Next slide, please. So this is the proposed solution. The technical infrastructure for this project has been stood up at NIH NCATS, National Center for Advancing Translational Science. So FDA, PICO researchers or other researchers will have access to the web-based portal that we have stood up, and then the tools, and they can query any of the 4 common data model. And then through the ETL process, we can have HL7 FHIR standard as output, as well as CDISC standard, which is required by FDA for submission of clinical trial data to FDA. Next slide, please. So this project, phase 1, we collaborated with 3 institutes from NIH, with the National Cancer Institute, NCATS, and National Library of Medicine, as well as the Office of National Coordinator for Health Information Technology, or ONC. And it was led by FDA. And these are the objectives of this project: is to develop a general frameworks, tool, processes, governance, and standards. So like the role of NLM in this project was to develop the governance model for this project. And then curation and maintenance and sustainability. I'm actually working on finalizing the report to HHS for this project. And then the second task or objective was to be able to, so HHS asked us, they didn't want this project to be an informatics exercise. They wanted us to answer a real clinical question. So we focused on safety of immunotherapy in patients with autoimmune disorders. So these patients, the patients with autoimmune disorders, are excluded from randomized clinical trial for this immunotherapy. So we wanted to see if in real world the healthcare providers prescribe this medication to these patients. And then the third task was to be able to leverage the existing infrastructure that has been funded by HHS, ASPI, Assistant Secretary for Planning and Evaluation, and they have this Patient-Centered Outcome Research Trust Fund, or PIC or TF. So one of our tasks was to be able to leverage what they have already funded. And one of the projects that have been funded by HHS is the NIH Common Data Element Repository. So we leverage that, as well as ONC's Data Access Framework. Next slide, please. And then continuing with the objective, one of the main objectives of this project is to leverage open standards and control terminology, and to be able to advance patient-centered outcomes research. And then be able to test methods and tools that have developed by one collaborative, for example, Odyssey, on another, on this harmonized solution. Next slide, please. So phase 1, our accomplishment have been we harmonized 5 common data model. Actually, PICORNet in the middle of our project, they moved to a new version. So we have harmonized 2 versions of PICORNet through an intermediary model, and we selected Bridge Biomedical Research Integrated Domain Group, which is as the intermediary model, since it has the CDISC standards and HL7 standards harmonized with it. And then we developed the infrastructure, as I mentioned, at NCAS to be able to query, and then for the researchers to get to the NCAS portal and be able to query the query of their interest from this solution, and also be able to use the open consensus-based standards. For phase 1, we collaborated with multiple data partners, with Mayo Clinic and Yale are part of the FDA CERSI, Center of Excellence for Regulatory Science and Innovation. So we collaborated with those 2 as the data partner, and we provided the immuno-oncology questions to them to provide the response to us. And then also we collaborated with Elico Health Research, and through Elico Health Research, we had 3 other data partners, IQVIA, Flatiron, and Hospital Corporation of America. Next slide, please. So phase 2 of this project started 6 months ago. It is funded by CEDAR 21st Century Cures Act funds, and we collaborate with NCATS together on this project, and NCI also participate, but they are not funded by FDA. And the goal is we are actually the phase of identifying new data partners to leverage the infrastructure we stood up in phase 1. And then one of the challenges we had in phase 1 was we had to simplify our query because some of the data elements we needed were not in the common data model. So we are going, the data partners have the choice of using the common data model of their choice to run the query, or we are also looking at querying directly the electronic health records. And some of the data partners have stood up HL7 FHIR repositories. So we are using an HL7 standard called CQL, Clinical Quality Language, which is FHIR-based, to query their FHIR repository directly. And then the goal is to enhance the existing infrastructure by leveraging the HL7 FHIR standard. So we are using FHIR not only as exchange data standard, but also as the repository at the data partner site. And then the third deliverable is to be able, as the results come back to NIH NCATS, to be able to convert them to CDISC STTM. CDISC is another SDO, Standards Development Organization, and one of the standards that CEDAR and CBER have mandated for submission of clinical trial to FDA currently is STTM, Study Data Tabulation Model. So then the results will come from data partners to NCATS. They get converted to the standard STTM, and they come through FDA gateway, and then they go through validation rules at FDA. And then the goal is to have an end-to-end solution from the data partner all the way to FDA. Next slide, please. So now I'm going to talk about how we are leveraging this infrastructure for several COVID-19 activities. Next slide. So the first project is National COVID-19 Cohort Collaborative, or N3C. This initiative is led by NIH NCATS, and the goal is to have a centralized, secure portal for hosting COVID-19 clinical data. They actually use OMAP Common Data Model as their anchor, and the other common data model are harmonized to OMAP. And the goal is to have a centralized repository with de-identified electronic health record data just for COVID-19 patients. And it's a partnership with several HHS agencies, ONC, CDC, FDA, and NIH, and the CTSA Network, Clinical Transformation Science Award, and then the Distributed Data Networks, we call Net Odyssey Act, ITB2, the regular ITB2, and then there's ITB2 Act and Trinetics. And then they also several other clinical data partners. This project has 4 work streams: data partnership and governance, focusing on data use agreement with the data partners as well as the researchers, the phenotype and data acquisition for developing the protocol. And I belong to the data ingestion and harmonization work group. And then there's also collaborative analytics to selecting the tool to do the analytics and machine learning on the data that they have received. Next slide, please. So this initiative is led by FDA, by our Deputy Commissioner, Dr. Amy Abernethy, and that is in collaboration with Rege Yuda Foundation and Friends of Cancer Research. And there is a large group of other stakeholders that participate in this initiative, and from other federal government agencies and academic researchers, and also health system. And this initiative has 2 work streams, one focusing accelerated parallel analysis, developing key research questions that multiple organizations and teams can address simultaneously, and the accelerator lab meeting that is to share findings from interested data partners on critical questions. So currently there are 4 parallel analyses going on, and Odyssey and PICORNet also and Sentinel are members of this initiative. So the difference between this initiative and the one led by NCATS is this is federated, uses federated architecture, and the Entry-C is a centralized repository of the identified EHR data. Next slide, please. So in this initiative, one of my tasks has been to identify and review COVID-19 data elements, which were identified by our Office of Commissioner, and then I provided it to our medical officers from Division of Antiviral Product to augment the COVID-19 data elements to see if any labs or any other data elements are missing. So then this step 2 is I try to leverage the work that we had already done in phase 1. And I forgot to mention all the data elements from the full common data model as well as bridge have been harmonized at NCI, National Cancer Institute, Metadata Registry or MDR, and their MDR is called CADSR, Cancer Data Standard Registry and Repository. And then step 3, since some of the data elements were COVID-19 centric, so we harmonized them to PICONET, ITV2, ACT, Sentinel, and OMAP common data model. Currently, there are 140 data elements that have been harmonized with this 4 model. And then step 4 was to harmonize the data element with US core or USCDI, United States Core Data for Interoperability, as well as HL7 FHIR R4. So where there were gaps in USCDI, we harmonized them with FHIR R4. And step 5 was to harmonize it with CDISC, SCTM standard. And CDISC has developed a companion guide for COVID-19 data elements. So they also provided that to us. And step 6 was to collaborate closely with the SDO, Standards Development Organization, as well as the technical lead from each one of the 4 CDM to validate the mappings that have been done. Next slide, please. So here is an example of 3 of the COVID-19 data element, and then the mapping to Sentinel, the PICONET, ITV2, ACT, OMAP, and then we actually harmonized it to 2 versions of OMAP, CDM 5.2 and 5.3.1. And then CDISC, and then USCDI and HL7 FHIR R4. And we are going to provide the gaps in USCDI to the USCDI work group of ONC. And then also we collaborated with Veterinary Administration and harmonized the COVID-19 data element to their current EHR system, which is VISTA. Next slide, please. And here is where you can download this mapping spreadsheet that we have done. And they have also been harmonized. So I provided the list to National Cancer Institute, and they have registered this list of COVID-19 data element within their metadata registry. Next slide, please. So now I'm going to shift and focus on a third initiative that I participate in. And this initiative is building on a project called OneSource. It's a collaboration between us and University of California in San Francisco. And the goal is to be able to use the electronic health record system at UCSF directly for I-SPY 2 breast cancer trial. These are adaptive breast cancer trials. And so we are the same infrastructure that we have stood up, we are leveraging for COVID trial. So to be able to test 7 or 8 different agents for COVID-19. Next slide, please. So this is the process. So the EHR system at UCSF, when a patient is admitted to ICU, then it triggers by the O2 order to the healthcare provider, to the ICU physician, that this patient might be a candidate for a COVID-19 clinical trial. And then the patient has a tablet so they can enroll in a clinical trial. And then also the healthcare provider is notified and he can sign off based on the handheld devices. And then we are building the COVID-19 case report form directly into the UCSF EHR system. So the data from electronic health record system is auto-populating the case report form for this COVID-19 trials. And then every night the clinical investigators reviews the electronic health record and augments the data that might not be in the EHR with additional clinical research data elements. So the goal of this project is to reuse of electronic health record in clinical trials. I think this is my last slide. Next slide. That's it. Thank you very much.
All right, thank you so much to all three of our presenters. We do have a number of questions in the Q&A feature. I think one thing I'd like to ask to sort of try to tie this all together, you all in various ways are involved in data harmonization. Are you aware of or have you considered sort of, I guess, collaborating, you know, from an HIE perspective as a data supplier to the research community and vice versa? What do you think would enable or promote that sort of exchange activity, and what are some of the barriers to it today?
Alice, I'll start just by saying the HealthShare absolutely is engaged with a variety of research initiatives. We have a use case that supports it. Now, we do have members that can opt in or out of that and have their data used in that particular research need or not. We are trying to automate through Market Street or other mechanisms a way to allow for an easier way to track and gather patient consent for allowing their data to be used in research to help that along a bit. But that's absolutely something on our roadmap, and we're doing it today with the consent of patient or with member consent.
Well, Ms. George, we engage with organizations that are interested in doing research, and the permission from the participants comes through that organization by whatever means, which varies by country and by type of organization. But obviously, we're a research organization, and this is our main focus in getting a 600 million patient record.
And this is me, Trasto, for one of our COVID-19 initiatives, the one led by FDA. We are collaborating closely with CRISP, which is Maryland, Delaware, West Virginia, and Washington, D.C. HIE.
And are you finding, you know, as you collaborate with that HIE, are you finding that you need to do additional, you know, data quality or harmonization work on the data that they're providing?
On the data, yes, we have to do the additional data quality work. And they are actually on the entry C, the other project, they have found like some patients whose temperature is 102, but then the unit is Celsius. So there are some data quality challenges with the existing data.
Marty, and maybe, you know, other speakers as well, what do you guys feel are the greatest, I guess, data quality challenges, and you know, how do we address those from a whole of industry perspective?
Yeah, I would just say that the pandemic response has kind of highlighted some of this for us, but really just consistency of the way each organization completes their data. Their workflow is a little bit different. The EMR and how it handles it is a little bit different. When we encounter information and the timeliness of that, and based on where the patient is in being registered or what stage they're in that particular healthcare entity, it's very different. And we've come up with probably 5 or 6 things. It's really going back to the source, talking to them about maybe a workflow adjustment, talking to them about, you know, the value and why we need to do this, and convincing them to take that time to then make that change. So it's in the trenches, kind of, you know, to deal with some of this. But I think with COVID, that's going to be a little bit of a bright spot there, as it's kind of giving a bit of, it amplifies the need for some of this and the importance of why we need to get it corrected or make it more consistent.
George or Mitra, do you have any thoughts you'd like to add?
I mean, I think we've shown that it's feasible to do this kind of work. So, you know, which is the worst challenge? I don't know. They're all kind of hard, but we've shown that they're all solvable, and that with a given use case, we just need to keep driving it forward. I think that we have to have specific projects that drive it, that allow us to go back and, as Mark said, you know, looking at the going back, iterate with the data providers to fix their problems, keep working on the standards, and keep generating the evidence or the decision support back to the doctors.
And George, while I've got you, there was a question in the chat about the interaction between Odyssey and FHIR. Some familiarity with the work that Georgia Tech has been doing to do that mapping, but if you could speak to that a little bit more, that'd be great.
Sure thing. And actually, I was just typing that answer in as we were talking, so I'll answer it verbally instead. So yes, Georgia Tech was the first working on that. There are a couple of efforts, you know, looking at that. I mean, FHIR's focus has been primarily on real-time interaction with the EHR so that we can provide decision support, although it's possible to pull the data out of the EHR one patient at a time and do many patients. Odyssey and OMOP's focus has been on creating a large database where you can put 100 million, 600, well, up to 200 million patient records in one database and have feasible statistics on it, where it's designed so that, you know, because you have 1 million rows and not 200 million rows and 1 million columns is a big database. You need to be efficient. So we use FHIR as a transport standard. Might be one way to get data into it, but when we're storing the data and analyzing it, we actually put it in the OMOP format. I mean, I understand you could use FHIR as a definition, and we're kind of looking at that. So it's kind of future work. But Georgia Tech had been the most advanced, John Duke's work.
Wanted to ask a question to each of you about automation and data quality, and to what extent is these types of transforms and data harmonization a manual process versus an automated process, and how could we make it more automated in the future?
I'll just go ahead, Mark.
Yeah, I was just going to say that I think given we've got, you think about an HIE, and we're all a little bit different the way we've grown up in each of our geographies, but if we've got the pipe already established and the agreements already in place to do some level of sharing, and it's standard based, I think that's a pretty good start, right? To automate or add to or increase the type of data that you're trying to collect. So that's kind of our feeling is, we want to continue to promote that we're pretty far down that journey and not reinvent, but sort of build on what we've already established, kind of thing.
Let's see, Alex, specifically on the data quality and automation, I mean, that is what we're working on, how to do that. I mean, there's always going to be manual labor when you're doing data quality, and you don't want to, like, people are smart and they're good at this, so you want them looking at the data and finding things that your automated systems may miss. Nevertheless, we create knowledge bases of consistency checks, so that the human part goes with the visualization, so we can kind of look at it en masse. And then the consistency checks looks for things, diseases that belong to one gender that are now reported with the other gender, or people who have diagnoses before they were born or after they died. All things like that don't just find those errors, but they point to other errors that often is a bigger problem back in the source system. So we're getting better at automating it, but I think there'll always be a large amount of manual labor.
This is Mitra on the data quality automation. In our collaboration with UCSF, they are developing a checklist to build for the electronic health record to be able to go back to the EHR as source and correct the quality of the data. in this also, because we are using those in randomized clinical trials, so the quality has to be very good.
Great, thank you. Unfortunately, we are running out of time. I'm getting the hook on the back end. So we do have to wrap up. I do want to give you all an opportunity to provide any closing remarks, recommendations for the industry, whether that's, use Odyssey to solve all your problems, or connect to an HIE, or anything like that.
Yeah, I'll just quickly say, we believe we're a community asset that in some cases is untapped. And again, depending on the region and where you are, there could be quite a bit of this work already underway or established. So leverage it. Use the HIE to its fullest potential, and we're thinking even well beyond that. So.
I'll just say thank you for the invitation. Odyssey.org. We're a voluntary network, so if anyone wants to contribute, please join us.
All right, real good. Well, thank you to all of our panelists today, and of course the audience for sticking with us in a little bit into your lunch break. We will reconvene later this afternoon with a panel about the transition from FHIR to, or document-based exchange to FHIR. So lots of exciting stuff coming up. Enjoy your lunch, and thank you again to all of our panelists.
Thank you.
Thank you.